we are not at the end of the story, not even probably at the beginning of the end of the story, but surely we are at the end of the beginning.
Yeah.
Saying that, questions for our panels.
Perhaps I will start because we have discussed second-line strategies, but now we have this situation of patients with early-stage disease, stage 3, that receive immunotherapy up front and progress. No? And in this situation, what we have discussed, so the treatment that we offer to our patients is exactly the same. So what is your recommendation for these patients who progress after neoadjuvant chemoimmuno or after Pacific trial?
It's interesting because it depends a bit. Well, you have to define the scenario of your patient, because depending when the relapse happened, there were two questions: the question of chemosensitivity and type of IO resistance, right? Because for some patients, they will have completed immunotherapy. For some patients, they will be very close to the adjuvant chemo, right? So having a dual kind of resistance. But let's speak about the most frequent scenario that we'll observe is probably these patients who are close to IO or under IO only and progress. Because for the other ones who are 1 year after all, you can start again with a standard of care metastatic treatment, probably. But when you really have this IO resistance, the next line should be platinum doublet, and nobody wants to give only platinum doublet. So we tried within ETOP to develop new strategies, so pushing companies, to maybe add a CTLA-4. It's maybe the time for 9LA, maybe it's the time for Poseidon, maybe it's the time for VGF, maybe it's the time for... the problem is it's a very risky scenario where we have no data. What about IO after IO when you still combine with platinum doublet? So I think this trial has still to come, where we create evidence about addressing IO resistance in the frontline metastatic patients. And I don't know which one would be the best strategy. Probably something giving rise to a better recognition of new neoantigens, because basically the failure of presentation of the neoantigen has been observed. But it might also be based on AGLA, and the problem is here you will be completely stuck, apart from creating a whole new paradigm of neoantigen kind of landscape. So I think it's still to do. Platinum doublet?
It's a differential situation, and we need to categorize the type of resistance. And in particular, when we talk about the resistance after adjuvant therapy, we really have to see where do we see the progression. Is this a distant relapse? It's a local relapse? It's a mixed relapse? And the timing really plays a role. And I think one point that we have completely forgotten in all this management of non-metastatic non-small cell lung cancer has been the part of radiotherapy. So I think, in particular, if you have a local relapse, there is still a role for chemoradiotherapy, and we do not really have got the full flavor of the impact on the immunogenic situation by radiotherapy. So we are just at the beginning. But it's going to be very complex. And as Solange mentioned, I think the people directly relapsing, these are the problematic patients.
Yes, please.
So maybe a relatively basic science question, but there are many studies now pointing at B cells having a major role in the response to immune checkpoint inhibitors, and all the drugs basically regard T cells, as far as I can tell. Did I miss anything? What do you think about this?
Yeah, we actually have a study like this in animals right now. And so it's true, we don't really know what the B cells are doing there in tumors, but we know about these tertiary lymph node structures, which are, of course, strongly associated with response to immune checkpoint inhibitors, and indeed also response to TIL. And that's really the missing component, the missing link, right, you say? You can have enough T cells, but if there's not enough antigen-presenting cells, forget it. It's not going to work.
Forget it.
Forget it, yeah.
So new therapy strategies tend to enrich in B cells, recognizing some of being specific and grown from the patients, but I haven't seen data at the time being. But for the other kind of solid tumors and usual strategies, we don't have any combinations. I haven't seen any combinatorial strategies, but it's probably true, right? We need to understand better and target.
Yeah. It's a hematological diseases there we use it, but there for solid tumors not.
No, but for basic science, from a basic science point of view, I do agree what you're saying. And Louise and I discussed it during the break also, that we told that the small cell lung cancer with those neoplastic syndromes do better, and that's also B-cell related. So there's certainly a role for B-cells, and we are doing some research on this, but this is again, B-cells are also, you think about B-cells, but also there's a broad plethora of all kind of B-cells with all kind of even regulatory B-cells, so it's getting quite complicated, but I do think we've neglected the B-cells too much, and this may be a new strategy of implementing.
Delvin, please.
I just want to say thank you, because I'm impressed with the amount of information that you have been giving right now. Sorry, Joaquin, for your lecture, because it was my fault, but you did very well. Well, as Solange said, I was very optimistic with TIGIT at the beginning, and the TIGIT pathway. Do you have any kind of information or hypothesis that you can say why all those trials has failed?
Well, the reason why I'm still optimistic for TIGIT is all of these trials have one common denominator. They show activity of inhibiting TIGIT. The problem we have is the magnitude, right? You've seen, for example, Sky1 has a 7 months difference in OS, but it is underpowered to become statistically significant. So meaning that we show this activity with all of these TIGIT inhibitors potentially really limited to high PD-L1 expression. There is some kind of complex loop to be defined in explaining that, but the activity is seen. The main question is there might be an additional compound or an additional selection process we should do to be able to reach a change of paradigm and a significance. Is it because we have somehow to qualify how much the TIGIT pathway is used? Or is it because by inhibiting TIGIT you're still kind of over-feedbacking the CD96 and the PVRIG? And for example, GSK has inhibitors of those three, an anti-CD96, an anti-PVRIG, and an anti-TIGIT. Of course, it is phase 1 of phase 1, very early phase 1 trial data, but there might be something about additional biomarker to obtain enough benefits to make a new standard, or to potentially block the TIGIT pathway, the CD226, in a complete manner. And still, we don't know. Very importantly, I guess, the problem of the size is you are in the high PD-L1, right? And if you really want to show a magnitude, it becomes huge trials, almost not doable. So I think that the mitigation from the trial, the pharmas, which today have not led to any registration. So maybe with a little more joint effort, you would have reached a positive trial, having all these patients, but competition is there.
And I think there are two additional points. Number one is the treatment situation where you are starting. So I think, as Joachim mentioned, it's not always a good idea to start in refractory tumors, and in particular when you talk about TIGIT. So this is not necessarily a resistance mechanism. And the other point is the dynamics. So when you look on Sky1, for example, there is an effect, clearly, but you do not see that after 1 year, and you do not necessarily see it in response. So we really have to change our assessment of endpoints and our assessment of efficacy. So sometimes perhaps we only have to wait and for some time to see the difference.
But also, I think also the development of the trials is and also what you learn from trial. And as a full disclosure, as Martin showed the trial on acasunlimab, and I was presenting that at ASCO. But I think the interesting thing about that trial is that there's also been T-cell dynamics studied, and what you saw is that when you give the drug concurrently with pembrolizumab every 3 weeks, then it would have been a negative trial. Yeah. But now you learn that because of this real activation of T-cells due to pembrolizumab, you do that with an interval in 6 weeks, and then you see the signal. And I think these are important things which we have neglected. Maybe with the TIGIT also, there may be something in the dosing or so, or which could lead to a potential effect. I don't know how much research has been done on that, but to me, this with the acasunlimab was very instructive.
Yes, and I think that maybe we need to do it intermittent. We don't know exactly.
And I think we really need something like a new classification of lung cancer, because it's something about immunogenicity which we are not capturing in our conventional system. We are talking about histology, we are talking about PD-L1 expression, but there's much more describing the immunogenicity, the microenvironment, and this is something where we need I think basic science and more understanding to categorize the different types of lung cancer that we are seeing.
Yeah.
And I guess that's a really great question for Ben. You know, we're always doubling down on the tumor, and yet since we started using checkpoint inhibitors, just like you said, we have missed the opportunity to learn so much. We don't look at MHC expression. We don't look at HLA. We don't look at the immune compartment at all in all of these trials or in the setting of resistance. What are some of the things, Ben, that you think we should be doing more routinely and we should be asking in the setting of resistance?
Yeah, I mean, certainly HLA is a big one, and you know, infiltration of T cells is important. We don't do a simple CD3 stain on a tumor, which would probably tell you a lot. And again, the presence, as we just mentioned, the presence of antigen-presenting cells, dendritic cells, et cetera. You know, you need kind of the whole family in order for things to work, just like that Tolstoy quote, if you will.
We need the Krelin score.
Krelin score, yes.
We have here another question.
Yeah, so hi. Thank you to everyone. So these were excellent presentations. So I have a question. I think that I mean, one of my question is, after I've seen all these presentations, all these, let's say, research, I'm wondering if we, as experts and team, let's say, can build type of research algorithms in order to orient, let's say, the actual path of the research. Because, for example, compared to before, we have some patients, especially in metastatic setting, that obtain complete response, also with first generation checkpoint inhibitor. So it looks to me that we are sometimes, obviously we want to pick up the stable disease patient or who do not obtain complete response. But I wanted to try to understand how we can, let's say, build an algorithm and where to focus also with clinical trials, to whom we can give more in first line, and how we can orient the patient in second line. Because, for example, my first guess or my first idea was, for example, if we can select before, which are the ones, for example, that can really benefit. So how we can, let's say, avoid or give to first-line immunotherapy with checkpoint inhibitors, which are well tolerated for our patient now, and try to focus only and give more to the one that they are, I mean, obviously obtaining stable disease or with chemo IO, how we can, let's say, spare chemotherapy. And to my opinion, for example, also in the resistance, the platform studies are very, very relevant now. So with different, based on the resistance and the mechanism of action. So I think we need to address a bit all these, which is very good because we need research, but we also need some directions.
Yeah, the problem is that we do not have really these categorizations. And it's a little bit coming very similar to the story when we talk about the patients with high PD-1 expression. And we say, well, we have the IO monotherapy, it's a good opportunity. But from our clinical experience, we do know that there are certain patients who need more. And we have worked on some characteristics. You can call this an algorithm to say, well, if this is a clear never smoker, we never would go with a monotherapy. We have other oncogenic profiling tools that we are using, but we never have confirmed this in a prospective trial. So this is a work ongoing. And this is one point. And the other point is immunotherapy is an indirect treatment. So we also have to understand the individual immune system. And there we are right at the beginning, I would say. I think currently I do not really have a good idea how to assess or to describe the individual immune system of the patient.
In your algorithm, you have 2 time points that I'm asking you. The baseline, where we tried to compare, and here the baseline, there is one confounder. I remember Matt Hellman worked a lot on that before going to AstraZeneca. It was the confounder of stable disease, roughly. Because stable disease very often defines a biology which can be everything but nothing, right? The slow progressors, the slow responders. So everything you try to define at baseline should probably characterize the progressive versus the responders. And maybe forget about the stable disease, which blur your picture. Even if they represent 30, 40%, they blur your picture. So going to the extremes. But here we have been looking at differentiator between responders and progressors. And the usual suspect, like PD-L1, tumor mutational burden, and so on, were not really helping in classifying. So as Martin was telling, it's probably more into the neoantigen presentation. The algorithms today are not very good in terms of trying to simulate what are the neoantigens based on the HLA composition, but maybe to know if a patient is prone to present neoantigen to the immune system is really something that we could be doing individually once the algorithm get better. But more importantly, apart from this individual assessment at baseline, what I would like to know is the evolution, right? What is happening in the patient when you give immunotherapy at the individual level and at the tumor level. And here, at least in lung cancer, we have nothing. It's about rebiopsy or liquid biopsy again, and how can you really observe changes over time. So I think we might learn really from the biology, but we are working more on commercial clinical trials than on the biology at the time being. So I'm not so sure that the priorities are really leading to that. But I agree with you, that's probably where we should move.
Yeah.
I would say the keep one, the bad KRAS, G12R, G12V, the large cell neuroendocrine, these are tumors where obviously we could do escalation up front of some type.
Of course.
And it would be well justified, right?
And the question is always, are we separating prognostic factors, or are we talking about predictive factors for the immunotherapy? So I think we can characterize a poor prognostic group of patients with fast proliferating tumors, but whether they do benefit from additional immunotherapy, we do not really know, because it's just our medical thinking that we are going to throw everything in the treatment to provide some benefit. But this is still something we need to confirm.
But at the end, in order to have these treatments in second line, we need a positive trial, no? So
it would be very helpful to have a positive trial.
And we don't have this, no? So how would be the best way to design these trials, not to be positive? Because I have the feeling that those patients that perhaps benefited to second line immunotherapy strategies are those patients with longer benefit to first line. I don't know, this could be an impression. But there is not clear definition of secondary resistance to immunotherapy or primary resistance, because we have patients treated with immunotherapy alone or chemo plus immunotherapy. So do you think this could be
I think this is something that we try to adopt in the novel protocols, that we said at least we would require some benefit from the first-line immunotherapy for a certain time with disease stabilization to exclude these patients with the primary refractory disease. But however, we are still waiting, even in this selected population, to see a confirmed benefit of a novel combination compared to docetaxel. And the other reason might be that, and this never has been proven by any trial, but it's some feeling that docetaxel seems to work very well after immunotherapy, because the survival times that we are seeing in the prospective trials are much better than the docetaxel values that we have seen in the old second-line trials. So there seems to be something, but I think we need some proof of concept first.
Luis, please. Micro.
Take care, Luis.
Luis.
Take care, Luis.
Please.
Slowly.
Slowly.
Okay, so thank you very much. Great presentations. I have to say that I'm a bit surprised from this very long list of agents. There is very little versus known bite in non-small cell lung cancer. So what I mean is, because we don't have the data as yet, so if you look at what happened over the last 2 years or 3 years, the really true game changer has been tarlatamab in small cell lung cancer, which is a very aggressive disease, very cold disease, and so some hypothesis that you're losing antigen presentation very often in that disease, you're able to activate T cells through a non-canonical mechanism is really working. So I'm a bit surprised that we were advancing so little. Because it's very important. If you look at small cell lung cancer treated with bites, response rate is pretty low. It's not dramatically high. I mean, ADCs do induce more responses as compared.
But the duration of the response.
But not only the duration of response. Actually, the benefit is becoming not only for responders, also non-responders. That happened as well with tebentafusp in ocular melanoma. Response rate is very low, but huge impact in survival.
All the lines are better, yeah.
So what happened is you really dramatically changed that microenvironment that we didn't study very deeply, but truly after a bite on something which is really cold or, a T-cell engager, you're really having the probability of maybe some of those drugs to really work then. Because if you don't have T-cell activation, I mean, just forget about T-cells.
I did not
about immune checkpoint inhibitors, right?
I did not cover the bites because it was not specifically my talk, but there is a growing list of bites being in phase 1. Bites, it can be like a brixtamig, an antibody with CD3 plus something else, or it can be a really bite. We speak about T-cell engager. It can be an antibody or a bite, which is a commercial name with a little peptide in between, or any kind of this construct. For example, a company in UK, Bicycle Therapeutics, which is doing lots of constructs, very modern, very flexible, penetrating the brain and everything. So all these kind of things can really be handled in a way which just has to bring together a CD3 moiety with the target and activating the T cell. But they're coming to, remember, the brixtamig has neuroendocrine large cell in the trial with kind of interesting response rate, so that the first data in non-small cell, and they are slowly coming to non-small cell. But when you think about, in general, the development of these bites, this is very slow. While in hematological malignancies, they know how to handle. I think for our environments, it's still a bit prohibitive because of the ICANS, because of the CRS, because of the management, the hospital-based kind of stay. So despite the fact that it's small cell, but beyond small cell in general, they are developing extremely slowly because it's not only lung. They can be developed in gastric, colorectal. So, but in non-small cell, there's kind of a growing list of compounds coming in phase 1, and we start to see them in the clinic. But I think the complexity of implementation for the nursing system, right, and the doctor system is probably one of the barriers. It's extremely expensive to develop.
Yeah, but anyway, so I mean, my reading is that people is investing more in other things as compared to bites. Yeah. There are some, but in solid tumors, I mean, I think they do have a big probability of changing the life to many patients. I mean, non-small cell lung cancer and breast or urothelial or whatever. And we are having still a list of, 20 TIM inhibitors or let's say whatever, TIGIT or so on. But
politically speaking, when the tarlatamab will be an outpatient treatment, because it will come, it will help. Because remember that in Europe, for example, all the billing system is limited by DRGs when it's hospital-based. So even for a pharma company, they will extract only half of the benefit they can do. So what I mean by that is as soon as it's going to be an outpatient with all the habitudes, right, and the habits of the teams, it's going to be probably something more dynamic, I would imagine.
And probably the next step would be biospecifics in first line. No, we have seen the results of ivonescimab in the presented by Joaquim. My question for you is: the study was done in patients with PD-L1 positive. What would be your thoughts of the combination of this biospecific plus chemotherapy? So for those patients with PD-L1 between 1 to 49%, or even for patients with PD-L1 negative, should we give these agents alone or in combination with chemotherapy or other potential approaches?
Well, I mean, to me, it seems. I mean, the way it's designed now is, of course, to have a positive sign for the trial. So I think that's logical, also, and also good that we now have a positive trial, so that something is taken further. But I do agree on what you're saying. What we learned from the PD-1 chemo also is that when you have PD-L1 negative tumors, then it's potentially better to combine it with chemo for the synergistic effect.
Dr. Mike.
Yeah.
Because they are not listening.
Sorry. So I do agree that this would be a beneficial way of doing it by adding chemotherapy to it for PD-L1 negative tumors, as we've seen also in the PD-1 story. So, and it will depend also on which antibody, which bispecific antibody you're going to take. It may be that, for instance, the acasunlimab is more effective in those patients who respond to PD-1 earlier. So maybe there's a role only in PD-L1 positive tumors. And for instance, as Solange showed, the CTLA-4 is a very different mechanism. And maybe that is the way to go in PD-L1 negative tumors to develop it. But I certainly think that chemotherapy can be a good backbone to combine it, as we've learned that it's synergistic.
I would love to see some survival times coming out of these trials. So currently we are talking about progression-free survival, and this is something we have learned from anti-angiogenesis. It has an impact on response, it has an impact on progression-free survival, but we have a couple of trials where in the end we haven't seen any relevant effect on overall survival. I think this also will be very, very important for future strategies, how to design trials with these new compounds.
And that's probably why in my last slide, I was telling it's difficult to develop new trials, right? Because somehow the bar is quite high with chemo-IO. You have a 20% long-term benefit and so on. And still we don't have enough new bispecific or new checkpoint combinations that allow you to get rid of the chemo without taking any risk. So in terms of creating a new strategy and opening the way of a phase 3 trial, nobody wants to take the risk of having what people called early progressor, fast progressor, hyper progressors, or failing that. So I think the bar is becoming high enough that you need to identify a super active, maybe I would say T-cell engager or something, which would really bring you to the idea that you can get rid of chemo. And in all of this bispecific we have now, none really qualifies for an activity which allows you to take this risk, right? So it's more about having active compounds, right?
As far as the BiTEs go, we'll see less CRS if we give BiTEs in the maintenance setting, because CRS is directly proportional to your tumor burden. Yeah. So that might be the optimal role for BiTEs for non-small cell lung cancer.
Maintenance or something?
Like a maintenance.
One last question.
I think also in combination with chemo. I mean, if you look at B-cell lymphoma, first line, I'm not sure CAR T cells could be any better as compared to chemo plus anti-CD19 BiTE. So, there is opportunities there also to combine with chemo first line.
Mm-hmm. What about the future of the vaccines? What do you think? What will be the place for vaccines?
This is your question.
Well, I think the future will. I think certainly vaccines is certainly one of the extra options which we will get in patients. And we've learned a lot about vaccines. I think we've also seen a lot of negative trials in non-small cell lung cancer, and it has to do with the way the vaccine is developed. It has to do with the stage of the disease, but for instance also whether the adjuvants used to induce an immune activation, you need some kind of inflammation to get the vaccine, to get the antigen presentation going for the vaccine to be effective. And one of the things we are learning, and that's also is what Ben showed, the HLA loss, but also the fact that antigens can be downgraded, so that, for instance, when you have a vaccine only generated, again, one antigen or two or three, that the tumors can downregulate that antigen or develop new ones, then they escape. So there are a lot of things which we've learned from vaccines, and that should be integrated in the various trials which are developed.
I think it's time to finish. I'd like to thank our panel discussions, our panelists, and my co-chair.
I think
thank you all.
Excellent.